I spend lots of my time talking with patients about cholesterol. We'll talk about that in this talk, but we'll also talk about some clotting issues. So this is part 2 of cardiac, lipid, and vascular. Here we go. So anticoagulation. So you have a patient and you think they either have a clot or they're at risk for a clot. So what are our options to keep them from, one, developing a clot, and two, keeping that clot from moving where it is to the lungs, to the brain, or someplace more serious? So if we think about the clotting cascade, it's actually a very complicated, very difficult thing to understand. And basically it comes down to understanding that the clotting cascade can be affected in a number of different areas. So most people, when they have a insult to their skin or internal organs, will try to develop a clot to block that opening. Using usually clotting factor 12 starts out, then it goes to 11, then it goes to 9, then it goes to 8, and then it often goes to 10, but only if going through the intrinsic pattern. Basically, I think it's not useful for the vast majority of clinicians to spend a lot of time thinking about this clotting cascade. Factor 6 doesn't exist. It's actually a duplicate factor from one of the others. So if you want to upset them the next time you give blood at the Red Cross, tell them you have a factor 6 deficiency. Factor 8 is the factor that is usually missing in a patient with hemophilia. So if we know that different drugs affect the cascade differently, we know that they're going to have different length of effect, they're going to have different side effects. Heparin is a direct antithrombin 3 inhibitor, and so it actually blocks the effect of thrombin and activated 10A. Activated 10A is very important in this clotting cascade, and if you block that, people don't clot. But if you also block thrombin, they're more likely to have other bleeding other places. So heparin is a pretty non-specific anticoagulant. You can actually affect too many places and have too much of an impact. And this is why when a patient is on a heparin drip, we have to monitor the blood testing, specifically the PTT, the partial thromboplastin time, and make sure that it's in a therapeutic range. Low molecular weight heparin actually acts only on 10A, and 10A actually has sort of a built-in governor, if you will, that keeps it from providing too much clotting. So in general, patients won't get too much clotting unless you really overdose them with a Lovenox or similar 10A type inhibitor. Warfarin is a medicine that was developed by the Wisconsin Agricultural Research Foundation, hence the name. It was actually developed as a rat poison, although the doses we use are far below what one would use to poison animals. In fact, rat poison no longer uses warfarin, it uses other factors. But if we block the precursors of thrombin, i.e. prothrombin, we can actually decrease the synthesis of clotting factors and impact the level of clotting. The thing with warfarin is that, one, because we're decreasing precursors, it often takes 24 to 48 hours to really have an impact on the clotting time. The prothrombin time is the time we measure for that. And the other thing to remember is it hangs around for a very long time. The prothrombin time is what we're really looking at. Usually when they report that, they also report a international normalized ratio of that. Just because the prothrombin time is affected by atmospheric pressure and a couple of other factors. And so rather than looking at the specific number, which changes from day to day, we look at actually the ratio between what that number should be and what we want the patients to be. So 1 would be the normal ratio, and so in general, for most things, we're going to try to keep that ratio between 2 and 3. If someone has a mechanical valve, we're going to try to keep it between 2.5 and 3.5. Now, beside warfarin, we have newer anticoagulants, which are called the NOACs or sometimes the DOACs. NOAC stands for novel oral anticoagulant. DOAC stands for direct oral anticoagulant. They're not quite as novel, I guess, as they used to be, so the DOAC seems to be a term that is increasing in frequency, but for this talk, we'll stay with NOAC. And so they have good long half-lives. They basically affect the thrombin directly in the case of dabigatran or dabigatran, which is Pradaxa, or they can actually block factor 10A in the case of rivaroxaban or apixaban, which are Xarelto or Eliquis. So just to remind us, Coumadin can't be used if you need anticoagulation right off. It takes 48 hours or so to actually have its impact because it works on a precursor to a clotting factor, not an actual clotting factor. The NOACs, of course, though, work on 10A or thrombin, so they do work right off. So if you have someone who has new onset AFib or has a lower extremity DVT, you can start them right on a NOAC. For both of those things, you would have to start someone on usually a injectable medication such as Lovenox or some other if you were really trying to get immediate anticoagulation. With atrial fibrillation, you don't necessarily need to get immediate anticoagulation. So sometimes we will start them on the Coumadin, but you do need to understand the implications of the onset of action. The NOACs essentially have no reversal agent. There is now a reversal agent for dabigatran, but that is not the one we're using most likely and most recently. The half-life of the NOACs is about 12 to 17 hours. That means that for the vast majority of people within 24 hours, the effect is going to be essentially gone. And so if you have somebody who's in an automobile accident, you can usually control their bleeding for that period of time, and then the NOAC is gone. In some emergency situations, for those of you that are doing acute care, you can give fresh frozen plasma, which does have the clotting agents, which haven't been interfered with. But in general, we think of the NOACs as having about a day to get clear. With warfarin, we can counteract the action with vitamin K. I think we've probably all seen it done, although I'm not sure that I really am convinced that many of the patients that I've seen, it really saved their life. The heparin antidote is protamine. Heparin has a pretty short half-life, though, so even in cases where people have received pretty massive doses of heparin, if it's the injectable intravenous heparin, usually we're going to just let it wear off and be metabolized as opposed to giving the protamine, but in some cases, protamine might be indicated. So just to remind ourselves of the different choices of the NOACs, the Pradaxa does have a reversal agent, it's direct thrombin, but doesn't seem to work quite as well as either the Xarelto or the Eliquis, so it has somewhat fallen out of favor. If you have a patient that insists on being something with a reversal agent, it is an option. The rivaroxaban is a medicine which is appealing because it's once-a-day dosing. It is very expensive, but they tend to provide a lot of coupons, so if you have someone that's going to be on, say, three months or so of treatment because of a DVT, lots of times you can at least get them started with the coupons. It is equivalent to being on heparin as far as getting started with Coumadin, so you can transition people pretty easily from the Xarelto or Eliquis to Coumadin as well if their coverage runs out. Rivaroxaban, the research is not quite as compelling in reduction of bleeding. Apixaban seems to have better data on that. I'm not totally impressed by the data. I don't think the numbers are dramatically different, but the Eliquis folks will definitely emphasize that if you talk to them. Now, it's important to remember that if you have someone who has atrial fibrillation, all of the ads that you see on TV talks about these medicines, if not caused by a heart valve problem. We're not really sure that they don't work in someone with a heart valve problem. They probably do work just fine, but the research was not done with people with a heart valve problem. The other complication here is that if you have somebody with atrial fibrillation and you go ahead and you check a echo on them, a pretty fair number of them are going to have heart valve issues. Is that heart valve issue causing the atrial fibrillation? That's a difficult call and oftentimes one that we defer to the cardiologist, but it can make things pretty complicated. So that sort of summarize anticoagulation. I know that there's probably a lot more to it than that, and we'll definitely talk more about it in class, but that at least gives you some basics to think about. So let's talk about lipids. Lipids, I spend enormous amounts of my time each day talking with patients about lipids. There does seem to be some real advantages to the medications which control lipids, but there is a great deal of cynicism out there about these medicines as well. So let's talk about it. So basically, the production of cholesterol is an extremely complicated process. I put on a bunch of images here, which really show just how complicated it is. Fortunately for most of us, what we're really focused on is not so much the chemistry of it, but the clinical implications of it. So we will talk somewhat about HMG-CoA reductase inhibition. It's important to know that that's where it works, because not only does that decrease the production of cholesterol, but that also decreases the production of some other substance in the body, such as the ubiquinones, which we'll talk about in a minute. I think that as time goes on, we're going to understand the chemistry of these medicines a lot better. There's great cynicism about them because they do seem to cause a lot of muscle pain, and a lot of patients are very concerned about that. I don't think that the percentage of patients that get muscle pain is anywhere near what a lot of the cynics suggest, though. So basically, when you have people who are producing cholesterol, the big things that you have to worry about is what types of cholesterol are they producing. And so the HDLs, or the high density lipoproteins, basically go out and chew up the old types of cholesterol, and so we refer to those as the happy or good cholesterol. The low density and very low density lipoproteins basically are harmful to the intima of the blood vessels. And so basically we try to keep those lower, both through dietary and exercise interventions, but we also try to keep them lower many times through medication, especially in people who have a genetic tendency towards both the inflammation of their intima and production of high levels of these bad cholesterols. So what are the kinds of things that make those bad cholesterol things deposit? Well, one of the things is interruption of integrity of the blood vessels. Now, one of the things that can do that, of course, is smoking. There may be other things that seem to do it. But when it happens, basically there's a little tiny thrombus that forms. Then foam cells, which are irritations to the endothelial lining, attract cholesterol. And then there is deposition of cholesterol into the lining of the blood vessels and a relative narrowing of those blood vessels. The role of inflammation is fascinating because we've looked at a lot of different measures of inflammation to see if we can use those to predict whether people will get lipid issues. Not great success so far, but somewhere down the road that may be a useful thing to think about. The one exception as far as success is aspirin, the anti-inflammatory. It does seem to decrease the inflammation along the blood vessels, as well as decrease the platelet cohesiveness as far as the platelets sticking to them. So what can you do to try to keep yourself from dying from a heart attack and dying from a heart attack associated with cholesterol? Choose your parents carefully. So basically, genetics is very important, and unfortunately, we do see people who have parents that died of heart attacks, and then they die of heart attacks as well. One of the things that's hard to parse out with that, though, is that many times not only are chemical processes and physiologic processes handed down, but lifestyle issues are also handed down. So if my father ate very poorly, there's a better chance that I'll eat poorly than if he had been a very healthy, running type person. Hypertension and poorly controlled diabetes also potentially inflame and irritate the inside of your vessels. High levels of thyroid hormone will also promote lipid metabolism. So this is a thing to remember when you have somebody that has hyperlipidemia. Make sure that you do have some thyroid testing that documents that they are not hypothyroid, because if they are, then their lipids will go up. When people are hyperthyroid, usually their lipids go down. So if your lipids are high enough, there's always going to be some interruptions in the arteries, especially if they're twisty and turny because of high blood pressure. Basically, if you've got high enough levels of LDL, almost anybody can get into trouble. There are people, however, who have pretty low levels of LDL that end up with heart attacks. And in those people, it's because they've inherited a genetic tendency to. So how can we decrease the risk of lipid issues and therefore decrease the risk of heart attack and stroke? The one type of medication that actually has some evidence for it, although the benefit is more modest than some people will tell you, are the statins. If you treat 100 people for 6 to 8 years with a statin, you're probably going to decrease their heart attack rate by about 3 or 4%. Again, not nothing, but not as dramatic as some people make it out to be. What other options do we have that will lower cholesterol? Well, we have the bile acid sequestrants, which we'll talk about in a minute, but those are hard to take and really have never been documented to decrease deaths. The fibrates, again, same thing, relatively expensive, no documentation that they decrease deaths. And then fish oil, which really does decrease your numbers pretty nicely, but does not really seem to have any benefit not only on deaths, but also on heart attacks and other cardiac events. There's one exception that I do use fish oil for, and we'll talk about it when we get there. Now, one of the side effects that people are very worried about and are very concerned about is the fact that there is some evidence that statins will increase your risk of diabetes. This is a real thing, but again, is substantially less common than a lot of people would believe. In a sample of about 500,000 Ontario residents, they found that the odds of developing diabetes was pretty low in the people who were prescribed statins. However, they did notice that it was a little higher than the people that weren't on statins. And so if we look at those, we see that Crestor had an 18% increase, Lipitor had a 22% increase, Zocor, which is simvastatin, had a 10% increase. Pravachol really had no increase and might have even shown a decrease in the frequency of the development of diabetes. So basically, the researchers summarized and said, you know, for every either 162 to 407 patients that you treat for 10 years or so, you might have one extra patient develop diabetes. And in that case, the diabetes is probably going to be pretty easy to control with medication. And the question is how does that compare to the numbers needed to treat for the statin benefits? And as I say, you know, for 6 to 8 years of treatment, you know, you get about a 4% increase. You know, this is about a 0.25% increase in the risk of diabetes. And again, it's pretty mild diabetes, and Pravachol is an exception to that. So is there some risk? Probably. Is the risk dramatic? Does not appear to be. So the ubiquinones. Now, we said that the HMG-CoA reductase inhibition blocks a number of different pathways. And so one of the common side effects of statins is that it increases muscle pains. One of the theories is that it does this by blocking the ubiquinones, and that we can counteract this by giving HMG-CoA, you know, compensation medicines, most notably CoQ10. CoQ10 has a lot of theoretical benefits. Hard to know how many of those are theoretical and how many of those are real because the research is not extensive. But in this particular case, there seems to be pretty good evidence that CoQ10 will decrease the risk of muscle aches and pains in people that are on statins. Now, another thing to think about is whether or not we should measure any of the anti-inflammatory or inflammatory markers. Two inflammatory markers that can be measured. One is homocysteine, and there are some theories that maybe measuring homocysteine is helpful as far as trying to stratify who is at risk for cardiac disease. And the evidence seems to be that it's not helpful. The question, though, is if we really did a good study, would we be able to find something? The problem is that the treatment for homocysteine elevation is usually vitamin B, and if the treatment is only going to be vitamin B, there's not really going to be a whole lot of incentive to put millions of dollars into treatment. This is why I do encourage patients to make sure that they are getting adequate vitamin B, though, if they are on a statin. The other question, though, is there are a lot of people, including the Lyme literate practitioners, that are very interested in homocysteine. I'll actually leave that discussion to the labs and diagnostics course, but also be familiar with the MTHFR genes, just because if those are defective, you will not be able to metabolize your homocysteine. I'm not sure that there are very many people that have heterozygous issues that will really cause problems, and the number of people that are homozygous defects are pretty rare. So again, it's something to think about and look into if this interests you. Now, another test that I don't really have a slide on here is the CRP. Now, the CRP is a great indicator of inflammation. The CRP usually is measured as less than 5, and then the number if it's higher than that. In patients with cardiovascular disease, we sometimes try to actually parse those out and look at the highly sensitive CRP. Some people will use measures of 1 to 3 being the normal, above 3 being more inflammation than there should be, and less than 1 less inflammation than is usually found. Some people will use this as kind of a tiebreaker. You've got somebody and they really don't want to go on a statin. You're worried because they have a high family history. And sometimes by doing that test, some people will convince people. Whether that's really an appropriate clinical plan or not, I will leave to your judgment. So platelet agents. So again, we want people not to clot. How do we keep them from clotting, especially in situations in which there's a lot of cholesterol? And so we can use aspirin, most commonly at the 81 milligram dose for heart issues, but sometimes at the 325 level for stroke. Plavix is used for at least 1 year after placement of a stent in the heart. It's sometimes used long-term after stroke. Ticlid is no longer available. So let's talk a little bit more about cholesterol in regard to the ATP3 guidelines. So the thing you're going to find out is that many of the guidelines that are out there now have competing guidelines, and the American College of Cardiology and American Heart Association put out a new set of guidelines in 2013. Personally, I follow the 2013 guidelines, but many people do not, and many people continue to use the older medications, even though the data seems to be less than compelling that they actually save lives. So again, let's look at the statins a little bit more. They reduce LDL by somewhere between 20 and 55%. Triglycerides go down about 7 to 30%. They raise the HDL modestly, 5 to 15%. And again, the major side effects are myopathy, increased liver enzymes. That muscle aches and pains, as noted, can be decreased by CoQ10. The increased liver enzymes, if it's less than double normal of the AST and ALT, lots of times we'll just monitor them. If it is substantially more than that, we may actually be in a position where we need to decrease or stop their statins. If someone has severe liver disease, obviously you're not going to use them. And there are certain drugs that will interact with your statins, which will show up when you do your drug interaction checks. So what are the CoA reductase inhibitors? Lovastatin is inexpensive. It's on the Walmart $4 list. The dose range is 20 to 80. It usually has to be dosed higher and a little bit more often. Pravastatin is a once-a-day medicine. It's a little bit more expensive, but as noted, does not seem to have the diabetes issue. Most statins are fat-soluble. Pravastatin and the Crestor, which is rosuvastatin, are both water-soluble. Because of this, many theorize they do have less muscle aches and pains and maybe doesn't have quite a tendency towards diabetes, although as noted, the Crestor did seem to have some. These other medicines, atorvastatin is Lipitor, which is a high-intensity statin, and really atorvastatin and rosuvastatin are the high intensities. Cerevastatin is a relatively new medicine that we'll be hearing more about, but I don't see it used commonly yet. So what are the benefits of statins? Well, we know they decrease heart attacks, they decrease deadly heart attacks, they decrease the number of people that need stents, they decrease stroke, and they decrease total mortality. They're essentially the only medications that do this, and this is why the 2013 guidelines basically said don't bother with anything else. There's really no value to it. The statins are really where the money is. So statin intolerance. Now, one of the problems with statin intolerance is that if the original research that's been done on statins, if you tell somebody that they're on a statin, the incidence of muscle aches and pains is above 20%. And so therefore, there does seem to be somewhat of a nocebo effect where you do get these side effects just from people believing they're on something that will cause this side effect. There are probably about, in the studies, about 35% or so of the people did get muscle aches. So that means that, above the 25% that got it from placebo effect or nocebo effect, there's at least probably 10% of the people that go on statins that really do get muscle aches and pains. I find that that's decreasing over time, especially if I frame it in a very positive way, especially if I start them out on a low dose. It's actually an interesting question. I know that the cardiologists argue that higher dose statins have greater impact. I'm actually not that impressed with that data, and I think just by being on a statin, you get most of the effect that you're going to get from the statins. The other thing is that they did a study on the Annals of Internal Medicine in 2013 where they had people that had said, I'm allergic to statins because they had been on one statin and had side effects, aches and pains or something like that. And the ones that were willing to be rechallenged, which of course is a selection effect here, they were able to get half the people to agree to try another statin, and 92% of the people did tolerate it. So for the majority of patients that don't tolerate one statin, if you can convince them to try another statin, there's a real chance that they'll be able to tolerate it. So the bile acid sequestrants. Well, bile acid is something that will cause the absorption of cholesterol in the gut and the absorption of fats in the gut. And so if you have it in your gut, you don't absorb as much cholesterol. These medicines also do seem to have a mild impact on the A1C in diabetics, maybe about a 0.2% impact, 0.2 measure on the A1C, but they do have some benefit for that. The problem with them is they cause a lot of gas, they cause a lot of GI discomfort in many cases. Some patients do find them to be helpful because they had diarrhea before and it does seem to firm them up. But the majority of patients do complain about GI side effects and will not stay on these medicines. So what do? They lower LDL, they raise HDL. Unfortunately, they often increase triglycerides as well, which may or may not be an impact depending on how high they are. As noted, GI distress, they can decrease the absorption of other drugs. There's certain types of hyperlipidemias that they're not appropriate in, and especially in patients with high triglycerides. I would actually say anything over 300, but they're saying over 400 here. I would hesitate. Any patient that has triglycerides over 300 is now at risk for pancreatitis, and so I'm very concerned about that possibility, so I would not give them any medicine that would increase their risk. They do decrease heart attacks, they decrease severe heart attacks, they decrease cardiovascular mortality, but they have no impact on overall mortality. You are just as likely to die if you're on these medicines. The question is why. There's some studies that suggest that people have more accidents. There's some studies that people have more liver disease. It's not really understood why, but your overall risk of dying does not go down with these medicines. So nicotinic acid, or niacin, is the other name for nicotinic acid. It has a lot of really great impacts on your numbers. The LDL will go down, the triglycerides will go down, the HDL will go up, probably more than anything else. The only other thing that really seems to raise the HDL this much would be alcohol. But unfortunately, a lot of people will get flushing and dramatic flushing, especially depending on the dose. The longer acting versions of these seem to cause less flushing, but really don't have the data that the short acting do. It can raise your sugar, it can raise your uric acid and cause gout. It can cause upper GI distress, and it can also irritate your liver. So obviously, if someone has liver disease, you're not going to do this. Obviously, gout, caution in diabetes, irritation of a peptic ulcer can happen. Peptic is a generic term meaning stomach or duodenum. So either type of ulcer can be referred to as a peptic ulcer. What's the dosing? The immediate release version, you're going to start out at like 25 milligrams and then build to 50. Eventually, you'd want to get up to 1.5 to 3 grams a day. The problem is that if you skip a dose, you basically have to start over again because the flushing can be dramatic. The extended release versions of the niacin, Niaspan is one of those, 500 milligrams twice a day. It absorbs very gradually, much less flushing. You can decrease the flushing with the short-acting one by taking an aspirin an hour or two before you take your dose, but it can be dramatic and uncomfortable. So what does niacin do? It decreases heart attacks. It decreases major heart attacks. There's almost a tendency towards decreasing total mortality, although we really have not been able to show that conclusively in studies. Unfortunately, the benefits are what appear to be substantially less than the statins. There are patients that insist on being on these instead of a statin. It has maybe some benefit, maybe better than nothing, but again, hard to tell. Fibrates will really lower triglycerides, as you can see there. So for me, I tend to use them only in patients that have really high triglycerides. The combination of a fibrate and a statin really does seem to increase the risk of myopathies. But again, low dose of the two might be an option. I have some patients that have triglycerides over 1,000. In those people, you really do need to get them down or they will end up with pancreatitis. But fibrates, in my opinion, have a pretty limited role. The options for fibrates, gemfibrozole or Lopid, is a fixed dosing, 600 milligrams twice a day. You can't go up, you can't go down. There's really not any options. Fenofibrate does have some options as far as going up and down, and clofibrate is an older version of that. So the fibric acids, they do seem to decrease the progression of coronary lesions. They do decrease coronary events, but again, they have no data as far as mortality. This is something that many cardiologists will try to do, and as noted, it's controversial, but it is frequently done. Another medication that you will sometimes see used that I don't actually have a slide on is Zetia. Zetia seems to work a lot like the bile acid sequestering agents. It decreases the absorption of cholesterol. The data is, in my opinion, sort of less than compelling for Zetia. There's no benefit for Zetia alone as far as what the data shows. There may be some benefit of combining Zetia with a statin. As noted in the guidelines, the 2013 guidelines do not suggest treating to a goal. A lot of cardiologists still do this based on the ATP3 guidelines and other opinions. The AACE guidelines do suggest treating to a goal, but as noted, the Zetia has pretty limited role. So secondary prevention. So primary prevention is when you put people on a cholesterol agent who have not had a heart attack. And this is the data that we really were talking about. Secondary prevention is when someone has really had a heart attack or really has some heart risk equivalents, and really diabetes is considered to be one of those. In those people, ATP3 suggests that we get them down below 100, and the AACE guidelines suggest that we definitely get diabetics LDL down below 100. Most patients will require drug therapy to get below 100, and then we try to achieve the LDL goal, and then we look at the other factors such as triglycerides, etc. So in people that are hospitalized, they want you to check that LDL within a day. Patients should go home if the LDL is high. And again, many of the cardiologists feel the lower the better. I'm not necessarily convinced by that data, but they definitely will put people on a high intensity statin and try to get their LDL down into the 30s or 40s if they possibly can. Their goal is actually usually under 70, but they really do try to maximize that high intensity statin as long as the patient's not having intolerable side effects. Lifestyle therapies are usually started simultaneously with the drug. Most of the newer guidelines do not suggest a 3 to 6 month trial of lifestyle therapies if people are high enough that drug therapy is indicated. So basically, in primary prevention, you have somebody that you feel would benefit. They have a LDL above 190. They have a 10-year risk of greater than 7.5%. This is the criteria that I use, which sort of combines ATP3 and the 2013 guidelines. So what do? You start them on a statin. Some people will use a bile acid sequestrant or nicotinic acid. Again, I do not because I use the newer guidelines. If you've achieved your goal in 6 weeks, and I always check a lipid profile and a CMP just to make sure that their liver functions haven't bumped, then you can actually go to a higher dose of a statin or go from a usual dose to a high intensity statin. And then if you still haven't achieved your goals, sometimes you'll refer to a lipid specialist. Unfortunately, lipid specialists are actually a bit hard to find. General cardiologists are pretty easy to find, but someone that actually has a specialty in lipids is often a bit harder. So you do the LDL lowering drug therapy. After 3 months of lifestyle therapies at ATP3. As noticed, the 2013 guidelines don't include this 3 months. You go straight to drug therapy if they meet the criteria, and then you keep working on it. Drug therapy, again, basically this is just saying what the previous slides had said. And again, if the triglycerides are high enough, you probably do want to lower them. Things that will lower the triglycerides, one is if their diabetes is out of control, getting their diabetes under control. Alcohol will sometimes raise your triglycerides. A little bit of alcohol will also raise your HDL, however, though. And so the other thing to lower triglycerides is exercise. Exercise works great to get triglycerides down. The problem is getting people to do a meaningful level of exercise. So this slide I could spend a lot of time talking about, but basically this is the algorithm from the 2013 set of guidelines. So basically they're saying, okay, let's look and see. In patients between the ages of 40 and 75, you compute a 10-year risk. If the 10-year risk is greater than 7.5%, most of those patients are going to end up on statins. Obviously, if somebody has clinical heart disease, they'll also end up on a statin. Most of those people will need to be on a high-intensity statin. If the LDL is greater than 190, even if they don't have a 7.5% risk, they do end up on a high-intensity statin. If they have diabetes, that's considered to be a cardiovascular equivalent. They need to be on a high-intensity statin or a moderate intensity statin if their risk is lower. And basically, I compute everybody's 10-year risk, even the diabetics and the others, just to see. And if it's high enough, those people need to go on a statin. It's your choice whether you do moderate or high intensity. Some people base that on family history. Some people base that on other risk factors. So what do? Well, I tend to follow that algorithm that you just saw. I don't use any medicines other than statins, except in the rare case of people with hypertriglyceridemia. If someone really cannot tolerate a statin, I have a conversation with them about the fact that I really believe that statins are the only ones that have any benefit. But if they did want to try niaspan or one of the other medications, I'd be happy to prescribe it for them. The other thing that you need to be aware of is that the European Society of Cardiology and the AACE did come out with newer guidelines, neither of which are being followed in a widespread way, but there are going to be some folks that are more aware of those and follow those. But unfortunately, like so many other things we deal with now, there are competing sets of guidelines. It really is left up to the individual clinician what to do. So I've offered you some information. We'll keep talking about it, and I encourage you to think hard about this, and good luck with trying to figure out exactly what to do.